Ladies and gentlemen, can you all hear me? Good.
Yeah.
Hello, let me introduce myself. My name is Piers Butler. I have the honour of being the chair of NHS South Yorkshire Integrated Care Board, and I'd like to welcome you to our first annual general meeting. And it's a delight to have so much interest from the public. It's great to know a number of you are on. This is a public meeting, which means that there is an opportunity for members of the public to ask questions, and we've allowed a time of up to half an hour at the end of the meeting for people to ask questions about any item they want. I can't promise we'll be on top of all the detail. I promise you we'll answer the questions honestly and openly as we can, and we'll get back to you if we need to provide more detail. So welcome. It's great to have so many people on. Let me do a bit of process first, and then we'll have a few presentations before we go to the questions. We've had a number of apologies for absence. I won't list them here. They will be on our website, and I can confirm that we are quorate. Additionally, there are no members' interests to declare over and above what we've normally declared in our register of interests, which again is visible for everyone to see. Let's move on to our presentations then. And first of all, I'd like to ask Gavin Boyle, our Chief Executive, to start with the review of the year. Gavin, can I hand over to you, please?
Thanks, Chair. I mean, again, not to repeat that, but it's just great to see so many people joining the call. And I mean, clearly this is our first annual general meeting. We're a new organisation, but hopefully building on the foundations of much good work that's been done in the past. So I've got quite a number of slides, but I will move quite quickly, and we'll make the slides available. But there are some particular points that I do want to draw out, and I guess it's worth saying that this is a reflection back on the year that ended back in April, but which to be frank feels like some time ago, and obviously we're focused on the here and now, and we're looking forward to the future as well. So I'll probably talk a little bit, not just about the year that's gone, but actually thinking about where are we now and where are we going, if that's okay. Next slide, please. So, I mean, this is just a bit of an infographic about the I suppose the scale of South Yorkshire and the elements that make it up. And I guess the point that I'd want to make really is that one of the things we're hoping to do through the Integrated Care Board, NHS South Yorkshire, is to get advantage from that scale. You know, if you think about that 1.4 million population, how do we take the benefit from serving such a large population in terms of how we organise ourselves and how we deliver our services? If we can get some of the component elements working more closely together, so whether that's our hospitals or our mental health providers, then I think we'll do a better job for those people. So there's something about how do we use our role as a convener, as an enabler for change, as an agent for transformation, in order to get the benefits of scale to improve the health and well-being of South Yorkshire people. Next slide, please. So I mentioned that we're a young organisation, so we actually came about in the 1st of July last year. So it was actually, whilst the year was in place. So previously, many of the functions that we've acquired were fulfilled by the former clinical commissioning groups in each of the 4 places: Doncaster, Rotherham, Barnsley and Sheffield. And with the passing of that, the Health and Care Act, the ICB took on those responsibilities, plus some regulatory responsibilities, but also particularly this role to act as I guess a convener and a leader within the system. So we sort of started the year, sort of at the end of the first quarter, but what we talk about today will be the whole thing. The Act was significant in a number of ways, not only the creation of the ICB, but I think particularly emphasising the responsibility of all NHS organisations to work in partnership. Now, of course, NHS organisations have always done that, but I think there's something quite pointed really about that responsibility being enshrined in statute, because you'll hear me use the word partnership a lot during this presentation, because this is fundamentally about the NHS working with others to improve the health and well-being of local people. And with that in mind, the third point on my slide is something called the Integrated Care Partnership. So this really is I suppose it's a partnership that's convened jointly by the 4 local authorities in South Yorkshire and the ICB representing the NHS in South Yorkshire, but basically coming together to recognise that improving health and well-being for local people isn't solely the responsibility of the NHS. And in fact, research would suggest that organised health services probably amount to about 20% of what you need to truly improve people's health. There are other factors, so whether that's employment or education, housing, etc. And that's why we've got to work together with our partners, particularly the local authorities, but the voluntary sector and others too, if we're really going to address some of the challenges that we face. Next slide. So I won't go through this in detail, but it's what I would call the wiring diagram for the system. So in the green box, I've mentioned the Integrated Care Partnership, which draws together the 4 local authorities and this organisation, the Integrated Care Board. But in terms of how do we kind of organise the services across South Yorkshire in order to play into that partnership agenda, that's really the blue boxes, and we do that in 3 ways, really. Firstly, there's something about how do we convene partnerships at place, so bringing together within a particular geography, whether that's Barnsley or Rotherham, Doncaster or Sheffield, but working with the local authorities, the voluntary sector in that place, and other agencies, as well as NHS organisations, primary care, the hospitals, mental health trusts, to work more closely together to deliver a more integrated and joined up service for local people. So that's the kind of place partnership dimension. One of the other of the 3 elements that I've mentioned is about looking across South Yorkshire. So how do we get similar organisations? So, for example, all of our acute hospitals to work more closely together. How do we get all our mental health organisations to work more closely together? Primary care, etc. So one of the things we do as the ICB is to facilitate those cross-system conversations, and we've got an increasing maturing set of collaboratives and alliances, particularly in areas like acute hospital services and mental health, where we're beginning to see the benefits of those partnerships. And then the third kind of dimension that we look at is on particular issues across South Yorkshire. So whether that's workforce or research and development or digital, how do we work together in a more organised way to make progress collectively as a South Yorkshire in some of those important areas of work. So next slide, please. So just coming back to the Integrated Care Board. So that's this organisation, this statutory body that we're reporting on today. It's worth just, one of the things we did when we first formed is we spent some time as all of our colleagues within the ICB thinking through our purpose. And in this slide, there's a bit of a statement of that. So it's about improving health outcomes, quality and experience of care, eliminating health inequality. I'll say a little bit more about that in a minute. And to ensure the people of South Yorkshire have access to services they need to live well throughout their lifetime. That's really what we're here for. That's our job card. And there are 4 particular things that we're focused on. So improving outcomes in population health and in healthcare, tackling health inequalities, enhancing the value that the taxpaying public get from our services, but also remembering that the NHS is a big, it's a big organisation, it's a big employer, it's a big purchaser of goods and services. So we've got a wider responsibility over and above our role as a provider of healthcare to support the wider social and economic development of South Yorkshire. So I'll just say a little bit on each of those 4, just to let you know kind of how are we discharging that responsibility. So next slide. So if I focused just on the areas around improving our NHS services, I mean, I've just picked on 4 areas, but we know from listening to the public that timely, convenient, fair access to services is something that's very much at the forefront of the public's mind. And I'm pleased to say that in some of the particular areas of focus around that. So, for example, access to emergency care. Can you be seen promptly in A&E? If you're on an ambulance, will you get handed over swiftly to the ED team? And I'm pleased to say that some really good progress has been made this year. Again, this isn't just about the relationship between the ambulance service and the emergency departments. It's the whole end-to-end pathway. It's about what's happening in primary care, what's happening in the emergency services, but also what's happening in terms of social care, and are we able to discharge patients in a timely way? So all of these things, partners working together, has delivered a better service for patients around access to emergency care. Still got lots of work to do though, so don't take any of this as a sign of complacency. We're on a journey. We're making progress. Lots to do. Elective waiting times. If you're waiting for a hip operation or some other planned procedure, we know the waits are too long in the NHS, particularly post pandemic. But again, we've been working really hard to reduce those waiting times. And I mentioned some of those collaboratives and collaboratives and alliances. So, for example, the acute hospitals in South Yorkshire are working together incredibly closely to try and accelerate our progress. But we've almost this year eliminated the longest waiters, the 104 weeks, 78 weeks, which are clearly much too long to wait for planned care, and we're making good progress in terms of seeking to eliminate over 65-week waiters by the end of this financial year, and then we'll go beyond. But we've got some big challenges though. So inappropriate out of area placements for inpatient care in mental health is a big area of focus. Again, the alliance between the mental health organisations in South Yorkshire, I think, is beginning to bear fruit, particularly in terms of how we manage the kind of front end of the emergency mental health pathway. But this is really an area for focused work, and I think not simply across South Yorkshire, but particularly in our places, because it's about how do you avoid unnecessary admissions to hospital care for people with a mental health condition, and when they're ready to leave those settings, how do we make sure that they're able to be discharged back home as swiftly as possible? Because by doing that, you create capacity in secondary care locally for local people when they need it, rather than having to be accommodated in a mental health facility, perhaps somewhere distant. The other area where I think there's been terrific progress and lots of hard work is around primary care. And I'll say a little bit more in a minute about how we're improving access to primary care. But it is a challenge because what the chart shows is, basically the demand for access to primary care is increasing. It has been doing for quite a while. So just working through how do we perhaps have a different offer for local people, perhaps to manage people's needs in a more effective way, other than just relying on primary care. So some big challenges around primary care. But next slide, please. I'll just focus on some of the areas I've mentioned. I won't do it in detail, but on this slide, I've just sort of pulled out some of the really positive work being done in the mental health, learning disabilities and autism space across South Yorkshire. So, I've mentioned mental health crisis, and in Barnsley, some great examples of what they're doing around their out of hours hub in Barnsley. In Doncaster, there's a real focus on young people and some of the challenges, particularly to mental health, that they face, and how do we work with our partners to provide a more joined up offer for those people. It's been terrific work in Sheffield, in Sheffield Health and Social Care, around the physical environment of the Michael Carlisle Centre, which I think was in need of investment, but they've done some terrific work in bringing that facility up to a better standard. And some really exciting work in Rotherham, which is trying to design services but led by service users and the public, and some great work done in Rotherham as well around suicide prevention, which we know is a challenge. Next slide. I've mentioned primary care earlier. Some really good news there. So one of my bullet points there, In South Yorkshire, we're fortunate enough to have the largest capital investment in primary care in the country. So we've got an investment programme of £57 million that we're developing new health centres. So 3 health centres, for example, in Sheffield, in some of our most least well-served communities, but also in Doncaster and Rotherham as well. So that's a major investment in the infrastructure for primary care. Contacting your practice is something that people tell us often is a struggle, and sometimes that's about availability of appointments, but sometimes it's just about the way that the telephone system works. It's clunky, you can't get through, nobody answers, and we're investing over £1 million in 40 GP practices that have outdated telecom systems, so that we can improve just the practical aspect of how do you get through to your practice on the phone. Next slide, please. Actually, sorry, before I move on, I must mention that during the year we had an expansion of our role. We also took on responsibility for commissioning community pharmacy, optometry, and dentistry. And just to say that we're kind of new to the table around some of those services, but we're really excited to take on that responsibility. And we're hoping that through developing our relationships more locally with those service providers, which previously were commissioned on a regional basis, I think we can do some really positive work to improve the public experience of those services as well. And one of the things I'm really passionate about is, at neighbourhood level, how do we work with our primary care networks and wider primary care, pharmacy, optometry, dentistry, community services to provide more joined up offer at neighbourhood level. And I think that change in responsibility gives us a real opportunity to do that. Next slide, please. I just want to say something. This is more about, I guess, more about physical health services and hospitals, but again, some great progress made within South Yorkshire over the last year. Particularly delighted to see the opening of the diagnostic centre at the Glassworks in Barnsley. I mean, 80,000 people or more now are receiving quite sophisticated diagnostic investigations within a facility in a shopping centre. And it seems to me that I mentioned before about providing services in a convenient way. I think it's a great example where we're seeking to work with partners to do just that. So it's a great partnership between the council in Barnsley and the Acute Trust there. So really good to see that. Some other examples there, where I think some of our provider organisations are leading the way. STH, Sheffield Teaching Hospitals, and some of their state-of-the-art diagnostic work. This example's around acute kidney injury and kidney failure. In terms of additional facilities, we've also seeking to open a £15 million elective orthopaedic centre at the Montague Hospital in Mexborough, which will help to provide dedicated capacity for some of our planned orthopaedic work. And then finally, terrific news about the National Centre for Child Health Technology, which will be a national asset, but will be developed and physically present here in South Yorkshire in the Olympic Legacy Park. So we'll hear from the Children and Young People's Alliance later, but particularly Sheffield Children's Hospital has done some terrific work to bring that really terrific development into South Yorkshire. And then the fourth one of our responsibilities is to tackle health inequality. So just wanted to say a little bit about that. And when I talk about our integrated care strategy that we've developed with our partners later, I will refer to some of the challenges. Sorry, next slide. I think increasingly, I think we look to our voluntary care sector to help us with some of those challenges, because I think one of the great examples, and we have something I think is about 8,000 voluntary organisations across South Yorkshire, but they're closer to our communities in many ways than we can be as formal organisations, and more importantly, they're trusted. by those communities. So I think increasingly working with the voluntary sector to be able to connect with our communities is going to be increasingly important. And there's just some examples there about the great work we're doing. So with our voluntary partners, so social prescribing, which is around using alternatives to medical and clinically based treatments to support, particularly in this case, improving people's mental health. Really kind of innovative approach, which actually, the research evidence and the economic basis for it is well proven. So helping taking the pressure off some of our formal services. Sorry, can you return to the previous slide? I've listed some other examples there. So, for example, the work we're doing with Sheffield Mind on the arts-based This Is Us programme in Doncaster around digital inclusion. I mean, digital is potentially a great solution to some of our challenges, but it needs to be accessible for people. And then I think I've mentioned the work being done around particularly green social prescribing in Rotherham. Thanks. Next slide, please. Next slide. Okay. Thank you. I think just the headline from this, without going through the detail, but there is something about investing in programmes to address health inequalities. And last year, I think across South Yorkshire, there was something like £16 million invested specifically in projects which are around addressing some of those differences in experience that we know exist for some of our less well-served communities. So it's really important to see that. And then my final slide on this topic is really about us as an employer. So next slide, please. So we employ in health and care, in paid work, about 80,000 people. So we're a big employer. So I think one of our responsibilities is to seek to become a more inclusive employer. And one of the things that we've launched this year across South Yorkshire is an inclusive cultures programme where we bring established leaders like myself with aspiring leaders, particularly from minoritised backgrounds, to try and support those colleagues progress in their careers, so that we become an organisation that's led in a more diverse way, and hopefully then able to make better decisions which reflect the diversity that exists within our communities. Next slide, please. Just to say, we do have financial responsibilities as an ICB, and obviously we're responsible for commissioning something like £3 billion worth of NHS services. And I'm pleased to say at the end of last year, we delivered our financial responsibilities, including over £170,000 worth of efficiency improvements. It is an extremely challenging environment, though, and as we progress this year and look forward to next. I mean, clearly those challenges increase, but in terms of 22-23, we delivered our responsibilities. Next slide, please. So just finally, I just wanted to say a little bit about that wider responsibility to work in partnership. And I mentioned the integrated care partnership, and I think we had our meeting yesterday, and we've been established for about a year now. It's chaired by Oliver Coppard, the Mayor of South Yorkshire, co-chaired by the ICB chair, convened by the local authorities, but increasingly becoming a real force to galvanise partners wider than just the NHS, but clearly the local authorities, voluntary sector and others to help us to address some of our challenges. And one of the things we did in March is we published a very explicit strategy with some bold ambitions to improve the health and well-being of South Yorkshire people. And I'll just say a little bit about that. So next slide, please. So I mentioned about the fact that we're trying to listen to what's important to our communities. So in developing that strategy, we engaged with around 3,000 members of the community to hear what they wanted to see in that partnership strategy. And there were three themes, really. One was about accessibility, so timely care in a convenient way. There was something about affordability in terms of access, reflecting things like transport costs and parking and medication and those sorts of factors. But also this idea of agency and people wanting more control over their own care. So we tried to listen to that and enshrine that those messages in our strategy. And what we've also done, next slide, is built on some of the work particularly done in the past by our health and well-being boards within South Yorkshire to analyse some of the challenges that face us, and they are significant. So we know life expectancy in South Yorkshire is about 1.5 years shorter than the national average. There's something like 7 to 8 years difference in life expectancy between some of our more affluent areas and some of our more deprived areas. If you travel across South Yorkshire, from one neighbourhood to the next, sometimes there's as much as a 19-year difference between lives lived in good health versus lives lived in poor health, particularly for those from underserved communities. So our strategy, next slide please, seeks to address those inequalities. And in the middle of this slide, there's something called our bold ambitions. And what we tried not to do as a partnership is to sort of boil the ocean and fix everything, but we did want to focus on these 4 things which we felt were most amenable to a solution at scale and using the power of our partnership. So it's about focusing on early years, so every child in South Yorkshire is school ready. It's about accelerating and strengthening our focus on the prevention of ill health and the early identification of disease, because we know that can improve outcomes, particularly in terms of cardiovascular disease or cancer. But also working together to improve economic participation. I've mentioned our role as a big employer. We can use that to improve economic participation, particularly in our deprived communities, but also to think holistically about our own workforce. So I mentioned the 80,000 who are employed by health and care, but there's something like 300,000 people who are involved in not only formal employment, but through voluntary work or acting as unpaid carers. So if we can think about that whole workforce and how we support and enable them, that's an important part of our strategy and our challenge. And then finally, in terms of the NHS, next slide, please. One of the things we're doing today is publishing our joint forward plan. So this is the NHS's plan, but it's the NHS's contribution to that strategy that I've just described. So this sets out precisely what the NHS will do to deliver those ambitions and address some of the challenges I've mentioned. Next slide, please. So there are a number of objectives which are shown on this slide. I won't read them all out, but it's things like improving access, working in partnership, supporting and developing our workforce. But it's a coherent and systematic plan over a number of years, which will ensure that the NHS delivers its part in improving the health and well-being of South Yorkshire people. Next slide, please. So it is phased over a 5-year period. It is a 5-year plan. We've got some immediate priorities which are focused on particularly some of those things that our public told us mattered to them around access, but then moving to a much greater degree into prevention and tackling some of those inequalities that I've mentioned. And then finally, in terms of next steps, we'll continue to listen. Next slide, please. We'll continue to listen to our communities and develop our plans as we go. Nothing stays the same. Things change, so our plans will evolve and emerge. We're conscious that this is also a time of change for the ICB, this organisation itself. We're currently reorganising ourselves to, I guess, reflect some of the challenges that I've mentioned and the changing role that we've taken on as we've formed. But again, I think the theme for today is all about partnership. I think what's increasingly important is that the NHS reaches out and works with those other agencies that I've mentioned, so that we can really make a difference for the communities we serve. Chair, I'll finish there and I'll hand back to you, but obviously I'll take questions at the end if there are any.
Gavin, thank you for that. Quite a run through of what both we've had as a year and what we've done, but also what we're trying to do. And actually, a number of those things are reflected in the presentations later. So I hope you get something out of that. I'm now going to ask Lee Outhwaite, our Chief Finance Officer, to talk you through our annual accounts and finance update for the year. Lee, can I hand over to you, please?
Certainly, Piers. Thank you, and afternoon all. So I'm Lee Outhwaite. I'm the Chief Finance Officer of the ICB. Don't know about you, but it feels a long time ago, the 31st of March away. It feels like a lifetime to me. So I don't know what it feels like for everybody else. So I'm going to do a bit of what happened in 22-23, but also a bit of a where are we at now and what are we working on. So next slide, please. Well, if you're a big fan of statutory accounts, it's been a bumper year for you because we've produced 5 sets of statutory accounts. We've had to produce 4 sets of accounts for 3 months for each of the old CCGs that ceased to be at the end of June. And in addition to that, we've had to produce a set of statutory accounts for 9 months for the new body, the ICB. The result of all of that work is, for the 12 months of the year, the South Yorkshire commissioning bodies delivered a surplus of £19 million. And that meant overall, as an NHS system, we delivered a break-even position. If you were pedantic, you'd go, we didn't deliver a break-even position, we delivered a surplus of £16,000. But that's not bad going on a £3 billion turnover. So a bit of a surplus in the commissioning sector and a bit of a deficit in the provider sector. And I'll go on to how that works a little bit more on the next slide or two. Next slide. Within that, as Gavin's already said, every year from a taxpayer perspective, there's an absolute right, in my opinion, view that the NHS can deliver efficiencies. We can deliver a more effective way to deliver services. Within that overall financial performance, in last financial year, we delivered about £178 million worth of savings. Some of those from the ICB, some of them in providers. The ICB savings tended to be around sort of medicines optimisation, choosing the right drug therapies, looking at how we spent money on CHC, continuing healthcare costs, and there were many different forms of savings in providers, trying to shorten length of stay where appropriate, trying to ensure we had the right sort of follow-up services in outpatients. So that meant within that overall 3 billion, we saved quite a lot. We saved about 178 million, a bit behind what we'd hoped to save, but we saved quite a lot of money. Next slide, please. In terms of where we're at for this year, and to be brutally frank, directors of finance in the NHS tend to appear every year and go, it's the most challenging year I've ever seen. It gets a bit repetitive and boring for board colleagues, but it is blooming hard. This year, 23-24, we've got a really large savings challenge as a system. We're trying to save about 108 million on a £3 billion budget at the ICB end, which is about 3.6 of the overall budget. And in the provider sector, we're trying to save about 133 million on a £3.3 billion budget. The reason why those two numbers aren't the same is we commission healthcare for the whole population as an ICB, and we have an inflow of patients that come in from Derbyshire and other areas because they're measuring slightly different things. One's representing the services we commission and one's representing the provider spend. But we've got a large efficiency saving requirement overall of about 8.1%, which we're currently trying to track down. Next slide. Worth reinforcing some of what Gavin said really about the sort of ICB role. As a CFO, I've got 3 responsibilities really. I've got a responsibility around finances for the ICB as a statutory entity. I've also got a responsibility for the NHS providers we've got hosted within the ICB. And then probably the toughest part of my role is how I act as a system finance convener for the system. That the local government funding regime is very different to health, but because of what we know about the social determinants of disease, if we can partner really well with local government and BCSE, we're likely to have a much bigger impact on health inequalities and those 4 strategic aims of the ICB. The finance picture for 23-24 is exceptionally challenging with that 8.1% efficiency requirement. We're dealing with a double-digit inflation rate in the NHS. That's the first time in my NHS career I've had to say that. We're working out what that's done to the overall cost base of the system and what we need to save potentially to compensate for that. And also, in addition to that, we're coming towards the end of the sort of COVID funding period, where there was additional money going in to cover the costs of COVID, and they're now being phased out. So as a consequence of those two issues, there's that large savings requirement. We're going to try and deliver as good a financial performance as we can in year, and we're speaking to NHS England about that. And one of the principal things we're doing is we're sort of thinking about how do we build capability for a larger program of transformational change from 24-25 onwards, because to be brutally frank, the NHS and broader public finance challenge isn't going to get any easier. And I'll finish there, Piers, and thank you.
Lee, thank you very much. Nice to finish on the challenge, because that feels real. We've now got two presentations, and actually they do reflect what we spoke about earlier. We talked a lot about health inequalities, and we thought it was important, therefore, that we painted you some pictures around that. So I want to introduce Ben Anderson, Director of Public Health for Rotherham, who's also a member of the Integrated Care Board, and Barbara Coyle, one of our staff, to talk about health inequalities in South Yorkshire and a bit about the sense of challenge that we've got. Ben, Barbara, can I hand over to you, please?
Thank you, Piers. Yeah, and thank you for the opportunity to speak at the AGM as well, I think. So as Piers said, I'm Ben Anderson, Director of Public Health at Rotherham Council, and also represent the 4 Directors of Public Health in South Yorkshire on the ICB board. And talking with me will be Barbara Coyle, who'll introduce herself in a couple of slides' time. But I just wanted to really thank Gavin and Lee for the strong focus on partnership, working with both the local authorities and the wider ICP partners across the system in their presentations, because I think that's really important. I think one of the things that we've got as a real success in South Yorkshire that's not in our successes section is just the strength of those partnerships and the way we work together. Next slide, please. So Barbara and I are just going to really run through some of the health challenges in South Yorkshire, and again, that reflection that these are challenges for the South Yorkshire system. Health is not just a product of health services and health service delivery, it's a product of a lot of social factors that we all work on, and particularly highlight some of those inequalities. And I think Gavin's already mentioned the 19-year gap in life expectancy that exists between different communities within South Yorkshire, and some of the challenges that we have as South Yorkshire compared to other parts of the country in terms of life expectancy and where we are. And then what we'll do coming to the end is look at some of the collective successes that we've had across South Yorkshire as a whole and within the 4 places, really taking forward some of that work and mitigating some of those issues and responding to some of those challenges. So I'm going to hand over now to Barbara, who's going to take us through some of the key challenges we face.
Hi everyone, and great to be here and co-sharing this presentation with Ben. So what does ill health cost us in South Yorkshire? Well, it's costing us lives. We're losing our parents, our grandparents, our sons and daughters too early, and certainly we compare ourselves to other parts of England, but also within the South Yorkshire boundaries as well. So we recognise that this is unjust, it's unfair, it's avoidable, and there's something we can do about it. And it's the reason why we've all come together as the ICS to have our working vision around why everyone in our diverse communities can live a happier, healthier life for longer. And the reason why we have to come together is because not one organisation can impact on this alone. We have to do it collaboratively, collectively. And that is because, next slide please, our health is determined by a range of complex, overlapping and interacting factors. There's no one cause for poor health, they are multiple. And if we look at that top sort of light blue colour at the top there, in the NHS, I think we understand about the physiological impacts. We understand what it is to have high blood pressure, high levels of anxiety, high cholesterol, and to what extent that then causes different diseases. We're also really well versed, I think, now in understanding health behaviours. We know that smoking is bad for us. We understand the impacts as well of diet, obesity, alcohol, gambling, and how they can impact those physiological factors. This model, by the way, is called the LeBomp model, and it's causes of the causes, because I think sometimes we don't talk enough about what causes those behaviours, what are the environments which are actually determining those. So we know in the healthcare sector, these are determined by the wider determinants of health, the level of income we have, the level of good schooling, good work that we've got, our housing, the environment, the air pollution we're exposed to, as well as the levels of racism or discrimination that we might find ourselves impacted on. And they have impacts, again, on the psychosocial factors, how we feel about ourselves, our perceived power, levels of isolation that we've got, and what we can do to support that. So each of these factors can directly impact on our health. We remember Awa Ashak, the young boy who died from exposure to mold in poor housing. I remember my dad. He died from lung cancer caused by asbestos from his job. They didn't give him any protective clothing. So we all understand, and can see these stories in each of our families, but also in our population. And if we go to the next slide, the impact that this is having at a South Yorkshire level, all these factors, all these individual stories are coming together at a population level, and that's what we've got to address. What we're seeing now within South Yorkshire, we've got nearly 30% of our children not achieving a good level of development at school. 6% of our 16 to 17-year-olds not in education training. We've got nearly 30% not in employment. We're earning less. That household and fuel poverty is an old indicator that is likely with the cost of living crisis to be much higher. And if people can't afford to heat their homes or feed their children, they're not going to be prioritising their health. And that is the sort of factors that we've got to kind of understand at the impact they're having. And that's leading us through then to why we might have, 60% of adults who are smoking and 18% who are binge drinking. Next slide, please. So I'm just going to focus on sort of 4 key challenges and opportunities actually we have to affect change and to get the improvements that we want. Next slide. I'm just going to talk about how we can move and the benefits of moving to a focus on prevention. So if we shift our mindsets and our approaches from treatment through to preventing that condition happening in the first place, there are opportunities for the patient, for the person, as well as the productivity of our whole South Yorkshire. But we have to match that prevention that we're doing to need. And there is this model called the proportionate universalism, which is basically where we know we want to improve the health of everyone. Everyone deserves better health, and we can give everyone in our society, better health. But we have to understand we need to do more in those areas that have the greatest need, that have the bigger inequalities. And it's kind of helping with that levelling up. That we need to make sure whether our investments are proportionate to the need. And as Lee mentioned, those are the sorts of things that we're thinking about. Next slide about prevention is we can do something about it. So the principal risk factors associated with the main causes of death, which are CVD, cancer and respiratory disease, they all have the same risk factors. And they are smoking, high blood pressure, diet, obesity and alcohol. So we know about 20% of deaths are due to smoking, 14% are due to high blood pressure, and we can map that through. But there is an opportunity for prevention here and to stop that happening, because if we know that 16% of our population smoke, we can support those and prevent those from happening. 37% don't currently have their blood pressure levels controlled to target. We can do something about that. If we've got 67% of our adults are estimated to be overweight or obese, there are things we can do to tackle that. So that's the main thing about prevention. There are opportunities there. Next. I just want to say a few things about the burden of disease is changing, and what we're seeing is people have more complexity and are more likely to have multiple long-term conditions now than ever before. And in fact, that people who are aged 50 in the most deprived areas have the same sort of health profile as someone who's aged 70 in the least deprived decile. So it's no longer a conversation about aging, it's about how old you feel at different parts of your life, and people in most deprived areas can feel older earlier than others. And in fact, you know, thinking about age, the last 3 years of your life are the most healthcare cost. So it doesn't really matter if that's at 55 or 85. It's the presence of that multimorbidity that is causing that for you to feel old. And again, if that's about morbidity, we know there are things we can do to prevent those. So that's taken us into this idea of primary prevention for all. And okay, you might get one condition, but what are we doing to stop you getting that next condition or that third condition to help you get better outcomes as well as preventing your decline? Next slide, please. Third element we've talked a lot about already, I think, and that's one of the reasons I joined this ICS, because we talk about inequalities. We have to be cognizant of our role in the NHS to make sure we're not making those inequalities worse. So we know there's this slope of inequality between those in the least deprived and the most deprived. Most deprived have worse outcomes. And this is an example for emergency admissions. Next slide. We are not, unfortunately, matching that with the elective care. So we have an inverse relationship. So in fact, those from the least deprived areas have more access to elective care than those that have got the high demand. So there's something we need to do to understand why is it that certain communities aren't getting that same access to diagnostics and to treatments that's getting them into their elective care. And that's one of the main roles we have to address within the NHS. Next. And just lastly, this kind of leads us on to my last point, which is taken from the Chris Bentley model, sometimes called the decay model. So we know there's so many people that might have a disease. So think of having diabetes, but then that drops when you think the amount of people we actually capture, the amount of people actually can access that blood pressure check or, you know, the blood glucose to know if they do have it. Because only when you do know it, do you get access to the treatment, and then that kind of decays again to actually those who can actually fully comply. Maybe they don't have the right support mechanism, maybe they don't have the digital tools that can help them with that compliance. So each time it drops. So our role really is to move that up. And if you think about that space in A, how to increase that the bar charts so they're all the same length. You know, let's put those blood pressure checks closer to where people are. Let's not expect people maybe to go and get those diagnostics. Let's go where people are. So what is it we can do at each of those stages to increase that access? So I'm going to hand over now to Ben. So those were all the kind of the challenges, and Ben's now going to pick up some of our approaches and successes in dealing with those.
Thanks, Barbara. So yeah, next slide. So we're just going to run through 5 examples that sort of really demonstrate some of the success we've had across the system, but also in relation to a lot of what Barbara's presented, and particularly the last slide with the Chris Bentley model around those areas where we need to intervene to increase the number of people who are aware of their condition, who are getting referrals to the right places, and who are complying with treatments that will benefit them as we go through that and level up those bars across the system. So next slide, please. So Barbara highlighted that smoking is still the biggest risk factor contributing to early mortality in South Yorkshire, with around 20% of deaths having a contribution from smoking. And the QUIT programme has been a really strategic, systematic approach to tackling that. And one of the things about tackling risk factors is it disproportionately affects those communities where those risk factors are prevalent. So we know that our more deprived communities who have the poorer health outcomes also have higher levels of smoking. So by having that systematic approach in hospitals to identifying who is a smoker and ensuring that at their bedside whilst in hospital they're getting the support, the brief intervention conversation, the signposting to services and the onward support where they accept it, around giving NRT, giving inpatient support, and then giving a referral on discharge into community stop smoking services is really, really important. There's lots of words on this slide. I'm not going to go through all of the detail, but just to note that we're now up to 84% of admissions having their smoking status noted at admission, enabling us to go through, have 10,000 specialist assessments undertaken at the bedside, and out of that getting 1,500 people successfully quitting for 4 weeks or more, going through. And that's really important because we know by doing this We are targeting those with the risk factor who we know come from our most deprived communities, and we're targeting them at a time when they are thinking about their health, in that they are in hospital, and we know that's a good time to start a behaviour change conversation with people. The next two slides we'll just pause on for a couple of seconds each for people to look. They just give case studies, firstly of one of our Sheffield Health and Social Care users who'd smoked since the age of 15, was also using cannabis, and has now achieved a 12-week quit. And just some of the comments on there, I'm not going to read them all out, but that they were noticing the impact that was having on their health, and the support they've had has not only enabled them to make that change, but has also given them the empowerment to start having different conversations with their social peer group, and move other people's risk as well. So really, really helpful. And then the second one, at the other end of the age spectrum, a 75-year-old who had smoked lifelong, suffered with COPD, so respiratory condition. Obviously, stopping smoking has made a huge difference. And again, that benefit to health that's there, and I think this one really recognises the difficulty in stopping smoking that people face. It's an addiction, it's very, very powerful addiction, and that craving for cigarettes is there, and actually the support that the quit programme and community stop smoking can offer really makes a difference to people's lives. Next slide, please. So we're going to go on to the examples from places now. So How's the Ticker is a campaign in Barnsley. Again, Barbara talked about the second highest risk factor that we have for ill health in our communities is high blood pressure. And what they did in Barnsley was go out, engage with the population and determine that males in the working age do not actively engage with their health until they are having symptoms of ill health. Blood pressure, we know, is a symptomless risk factor for many. So huge amount of high blood pressure out there that's undiagnosed, and in that first phase of the model Barbara showed, if we don't know about a condition, we can't make referrals, we can't provide support. So How's the Ticker went out, and if we move on to the next slide, over 300 sessions been delivered in targeted venues where we can attract men in that age group that we know. 5,000 people having their blood pressure readings taken, 41% of those found to have a raised blood pressure. Now, some of those it'll be a raised blood pressure because you're having your blood pressure taken, but that's a hell of a lot of men having that identified and having that opportunity to go through and get there. And we know that 25% of those that were identified came from the 10% most deprived neighbourhoods in Barnsley. So again, really good targeting of where we know we've got excess need, giving that extra support to identify people who don't engage and bring them through. And I think that's a really big theme of all of these examples is it's the extra support that certain communities need that we need to provide to make sure we get that preventative care in early and make a difference to those lives. Next slide, please. So the example from Doncaster is around their digital inclusion programme. Really busy slide, and apologies for the size of some of that, and you won't be able to read it all. I think the slides will get shared. But really, this is about that disproportionate input that you have to put to people to help them be able to engage, access, and then help themselves. And we know that in our most deprived communities, digital access is poor. So through this, there's some hardware support to give people the tools and the technology to be able to access things. And then there's some skills support to give people the skills to actually use that technology, manage their access, be able to do online appointments, be able to gather information around how to self-manage, self-support, be able to use some of the apps that are out there. And then the other one is the work with the Good Things Foundation, which for those that actually don't have the financial assets to have a good connectivity, good data access, again, being able to provide SIM cards that have got preset data access to give people the access to services. And one of the biggest successes I think we had during the COVID pandemic was moving lots of things online, moving lots of things towards digital access. But as Barbara said, one of the things we have to be acutely aware of is that the things we do don't exacerbate inequalities. And obviously for those that were digitally excluded, that was really, really difficult. So again, a really, really good service that listened to the communities, listened to what they need, and has helped change those skills and changed what's there. Next slide, please. So next piece of work is a slightly different piece of work. So it's not necessarily an intervention, but work that was done in Rotherham around the population health management programme we had as part of the place development programme that was supported by NHS England. And what this gave us was really the time and resource to do some good data analysis and understanding, and look at a lot of our approaches in the NHS are about those at the top of the pyramid who are in and out of hospital, regular attenders, all of those things. And what we wanted to do was say, well, actually, who are the cohort that are most open to prevention at the moment? So they're not seeing health services, they're not that ill yet, but they are the people who in 5-10 years time we will be seeing a lot of, and if we can change that now, we can make a difference. So working through that, we pulled together all of the data, all of the strategies, and looked at where we are and looked at breaking down our population and identified that actually there's a working age population who have already got multiple risk factors or diseases, including mental health, which a mental health condition, which means engagement is difficult, chaotic lives are difficult, working age, so managing families, managing work, health is not the key priority at times, and looking at, well, how do we work with those people? And that's led us through now to a programme working in Maltby and Dinnington, which are two of our most deprived areas, again, to look at how can we do long-term condition management for that population better and differently, so we get that universal proportionate universalism approach, and get them engaged early to keep those long-term conditions managed, where we can reverse some of those long-term conditions, and reduce that demand that we know will come from that cohort in 5-10 years time. Next slide, please. And final example from place is from Sheffield and the Citizens Advice Bureau support that again has been targeted. So again, that recognition that some communities need additional support to be able to access service, and actually that there are significant social factors that stop people having health as their number one priority, but also engaging with health services and following treatment. So actually clinicians can't solve all of those issues, but by bringing advice services into GP practices within three of the most deprived areas of the city, that's meant there's an ability to refer people, get those social conditions sorted out, make sure people are maximising their benefits in income, and able to engage, having support around housing problems, workplace problems, all of those issues, and moving that through. And again, by targeting the support, we know we're getting it to the right places and moving it through. And really strong evidence base that supporting those social and financial needs really makes a difference to people's ability to self-care, but also to engage with services where needed and comply with treatments. And we know people are having financial troubles at the moment that mean even when they are complying, they're making choices about whether to take their prescription medications or not, making choices about whether to travel to appointments or not, purely based on financial factors rather than the desire to move through. And the model gives all those opportunities and is being evaluated by some of our independent GP fellows as well. So there's lots more learning for that and looking at how that can continue to work in South Yorkshire. And I think the next slide should be the final slide. So yeah, just a summary of where we are and what we're looking at. So developing the prevention pathway, making sure we are addressing things like smoking every opportunity we can, that we're identifying and finding blood pressure and getting the support, and having that systematic approach that's there in the QUIP programme that says we don't do this incidentally by who declares their smoking status to us, but we actually actively look for it amongst those communities we know are at highest risk. Second one, supporting prevention and early diagnosis of chronic conditions. So again, we know that getting in earlier gives us the opportunity in many things like early onset, early stages of diabetes, to actually reverse conditions, stop people having the chronic condition in the first place, but also to support management and self-care that means people don't have the poorer outcomes later on. Number three, really important, tackling the clinical variation. So we know that clinicians who work in our most deprived areas have a much more challenging time. We need to make sure they have the resources and the support to be able to deliver the same level of service. And as I say, delivering the same level of service sometimes means putting disproportionate amount of resource into it to help people engage and help people be supported, and then really challenging that clinical quality across our system. Say, have we got the best quality in those places with the highest levels of need? Harnessing the roles of anchor of partners as anchor institutions. So actually we do much more than deliver healthcare in the NHS, involved in curing, employing, all of those things, and all of those things give us an opportunity to deliver social value, to support local economies, all of those things that we know make a significant difference to what's delivered. And then strengthening our understanding of health inequalities through data intelligence and the Rotherham work around actually looking at what do we know about people, how do we understand a cohort, how do we help them to help themselves, and how do we get into them and help them to engage, really, really important. And then final point is just that advocacy for prevention across the system. We know that prevention tackles the risk factors and the early onset of ill health and will help people live longer without the need for support and care. So financially, much, much better for all of us in that people aren't placing demands on the system, and health-wise, much, much better for those individuals and the communities they live in, having less burden of disease on them. And that burden of disease often leads to poorer economic outcomes for people in that health impacts their ability to work and their ability to be productive in our economy. So thank you for listening.
Ben, Barbara, thank you for that. I hope the members of the public who were listening got a real sense of what we're trying to do here as an ICB. This is not just about can we make the NHS more efficient. We will fail if that's all we focus on. We've really got to reach out into communities and get at health equity, because that's the way we're going to make a real difference. And as an ICB across South Yorkshire with our partners, we're absolutely determined to do that. Ben, Barbara, thank you for that. It was a really, really helpful and quite illuminating talk. We next want to talk through, Gavin touched earlier on children's services and how do we get things right for the adults of tomorrow. And both Ruth Brown, Chief Executive Sheffield Children's Hospital, and Nicola Ennis, one of the staff here in South Yorkshire, are going to talk you some work they're doing through the Children and Young People Alliance. Ruth, can I hand over to you, please?
You can. Thank you, Gavin. Good afternoon, everybody. I'm Ruth Brown. I'm Chief Executive at Sheffield Children's, and Nicola will introduce herself in a moment as well as she talks. And just to say as well, I think we've got Alicia Sampson on the line as well, who is our new clinical director in the Children and Young People Alliance. Alicia joined recently, and opportunity to say a huge thanks to Dr. Nick Jay, who has been our clinical lead before Alicia as well, and contributed a great deal to much of what we're going to talk about today as well. So thank you. If we could go on to the next slide. So for today, we thought it would be a good opportunity for us to talk to you about some of the work we're doing around children and young people in South Yorkshire. And it's a good opportunity for me to say, actually, we've started channeling a lot of work and focus on children and young people. And huge thanks to everybody who's part of the Integrated Care Board and all of the partners that are within that, for recognising just the scale of what we need to do, but the opportunities that we've got by working together as partners across our healthcare and wider system as well. So thank you to everybody for everybody's contribution, because this work has come about by lots of people being involved from many different sectors. And that is what our Integrated Care Board and work across the partnership in South Yorkshire is all about. So the Children and Young People Alliance is really focused on where we can make a difference to the 328,000 plus children and young people that live within our communities, more if you go up to age 25. And we've got a huge opportunity opportunity to make a difference now and for future generations, for all of those that live within our families and communities in our system. So we're going to talk through the sort of growth of the Alliance, the work that we're doing in our system and how we're bringing what our strategies are together and the actions to life across South Yorkshire, and then a little bit about our future and what's ahead of us. So I'm going to hand you over to Nicola to just talk you through the rest of the slides, and then I'll just come on to that bit at the end. So thank you, Nicola. I'll hand to you.
Thanks, Ruth. Good afternoon, everybody. I'm Nicola Ennis. I'm the Children and Young People's Alliance Programme Lead for South Yorkshire, and it's a real privilege to be here today to talk about the work that's taken place, not just recently, but in the past as well, as part of making a difference to children and young people in their lives. So as this slide says, I'm going to talk a little bit about from small beginnings, and Gavin mentioned when he started this meeting that actually lots of things have gone before where we are right now, and it's really important to understand how that work has really been the stepping stone for where we've got to today. So next slide, please. So in our system, really, in system working and working in partnership, we started that as part of paediatric hosted networks. So working within our PGHs and trusts and anything to do with acute settings for children and young people around 2019. And that work was looking at care of the acutely ill child and thinking about surgery and anaesthesia for children and young people, thinking about equity, quality, and sharing guidelines, sharing training together. And that was our initial way of working together across the system. And then in January 2021, NHS England produced the Children and Young People's Transformation Programme. They set up a national team for children and young people. And this is the first time within NHS England where there's been a real focus on children and young people, which has been fantastic. And as Ruth said, has really helped us be able to champion that not only at national level, but thinking about regional and system level. And in the transformation programme and plan, that is linked in with the long-term plan and then our joint forward plan. So really changing how we think about children's services, so not to 25, it's thinking about inequalities and improving outcomes with a real drive initially on thinking about long-term conditions, so some of which Ben mentioned, but for children and young people, so thinking about diabetes, epilepsy, asthma, and also thinking about obesity and weight management as well. The programme's wide, there's lots of different things within it. I won't touch them, but they're some of the things that's worth mentioning, and I'll talk about things a bit more as we go through. But one thing that came together when we started to move from paediatric hosted networks into thinking about this massive big transformation programme work was that way of being able to partner with people in a whole different way. And when we first met with people online in May 2020, I think it was, to touch on this programme of work, we had a guest speaker who talked about that ancient proverb, it takes a village to raise a child, and that resonated with everybody in the meeting about how we're all in, everybody's all in this in order to make a difference. Next slide, please. So again, Gavin said I'm going to talk about partnership a lot, and it's exactly the same within the work that we're doing in the CYP Alliance. The partnership work is key. I mean, so fortunate to have people who've really come on board and grabbed this in terms of the opportunity to be part of the Alliance. And across all our partners, we have people who are members of the Alliance, 350 members and growing. There's still many people that we need to make connections with and join up work, so we're doing stuff well once. But for now, one of our real core aims is to support a complex system to work together well, to facilitate some strong connections and to guide people to the right spaces to work in partnership to create change. Sometimes it's not about us specifically, but making connections with others, and off they go and they start to do stuff together, and that's fantastic to see. Next slide, please. So a bit of our highlights from 22-23. Next slide, please. Core to everything that we do, really at the heart of it, is making sure that we understand the needs of our children, young people and families and what really matters to them. Also touched on earlier about what matters to our population, but drilling that down into children, young people, and that's where we started. So asking that question, what matters to you, initially about your health, but it's become a lot broader than that, as it should be, because it's a holistic approach to children, young people and families. And so we did some co-creating work with children, young people and with organisations who work in partnership with children, young people and really promote the voice of children, young people to understand how best to do it as a system. It's a very different way of doing things. And we wanted to make sure that we really understood how we could do that and be able to hear from as many as possible. So we worked through that. We opted not to go for a board, and we have a model that we call Core and Connect, where we went to tender, and really fortunate to have voluntary organisation Chili Pep who lead that work and have been instrumental in lots of different work across raising the voice of children and young people within our system for quite some time. So that's fantastic. And within that work, we took that to our conference this year, which was very much hearing from children and young people and what it is that was going to make a difference to them. And we agreed in that meeting that it isn't just about amplifying the voice, it's about having a snowball effect, and it's about more than just amplifying, it's about taking it to the next level about that so what. And Ruth will touch on that a bit more at the end. Next slide, please. Oh, sorry. We don't need to hear that, it's fine, thank you. Also, one of the fantastic opportunities really of the national programme and being part of that has been able to access funds and money to be able to start to really make traction and progress with the work that we're doing. And it's broad brush, it's over lots of different things. I'm going to touch on a few things here. So one is around an abdominal pain pathway. So really trying to avoid children, young people having their appendix removed when they don't need to. And that's been rolled out across our system. But one thing that was identified was sonography, and actually it's really tricky to be able to identify appendix in children, young people and see whether there's something that needs to happen or not. So being able to access funds to help skill up that is one of the things that we've managed to do. Introducing new roles into workplace, so physician associates in paediatrics, thinking about asthma and that bit that I touched on about long-term conditions. So we've just launched our asthma-friendly schools policy, working in collaboration with education. Violence reduction and thinking about youth navigators and how we can support our most vulnerable young people in terms of gangs and crime and all those types of things, and being part of violence. So we've got youth navigators who are going to start to work across our system. And I could touch them all, but I won't. One other thing is just around diabetes and being able to reach our heart communities where they are unable to access tech. We know they are for lots of different reasons. So we've had funding to be able to look at that in Rotherham and Doncaster. Next slide, please. I'm calling this the umbrella effect, but it's just thinking about the alliance and its role. And I see it more a bit like the children's parachutes that they used to use, where you could fling them up, all hold an end, fling it up, and then you're under it. Everyone jumps underneath it and everything sits underneath it. And it's a bit about how we're working as a system and trying to bring our strategy to life. So it's strategy, but then what are we doing about that? So next slide, please. And so again, really fortunate to be able to have opportunities and funding to come into our system to think about that. We've got an early years pilot that's about to start that aims to ensure pregnant women have access to best advice and adequate supports to follow-up services. But it's more than that. It's about working in communities. It's about really understanding that need. It's about access and bringing service to what it is that's most important to that family, to that pregnant woman and that family at that time. And we're going to test that out in some of our most deprived neighbourhoods across South Yorkshire, very much linking in with other services that are there, family hubs, but really excited about the opportunity to make a difference there. We have something called the Core 20+ Oral Health Connectors, and that, again, we know that oral health for children and young people is a real issue, and that has a massive ripple effect on their life and their learning and outcomes. And so we're working alongside young people in different communities to say, how can we make sure that we do this right? How can we get good messages out to young people? What is it, the barriers to accessing good oral health? And we've just started that work, and we've met with some Roma pupils, and we're starting to produce some stuff to be able to support that. And then again, we are working alongside Sir Michael Marmot and Bernardo's in what we're calling a health equity collaborative. And within that, we're wanting to look at a health equity framework, which will really help us drill down into where services need to be for children and young people. And so recently, we've engaged with children and young people across the system. It was about 70 or 80 for South Yorkshire, of where they were able to say what, in terms of them, what really mattered to them in this health equity work that we're doing. And the things, it's quite stark actually, what they fed back. So one was around feeling loved, feeling safe, and it's safe spaces at home and safe spaces in the community were some of the highlights, but we're going to share more than that later on. Next slide, please. Back to you, Ruth, sorry.
Thank you. Thanks, Nicola. And we're very, very fortunate to have Nicola in as our programme lead as well for this. So thanks, Nicola, for everything that you've described there and all your hard work. I mentioned a sort of thank you to so many people who are a part of what we've done in South Yorkshire over the last year, but beyond and previous to that as well. And you are all part of our snowball effect, whatever your role is, and our kind of constant call to action that we need across South Yorkshire. We all want to be safe, feel loved, and you know, being a child in that environment is never more so important. And just come back to our sense of there are 328,000 reasons to create change, more if we think beyond 16 years as well. So thank you. Next slide. So one of the things that we've tried to do, and I'm sure Will Cleary-Gray's on the meeting as well and has helped us with this as the executive lead, is think through how do we describe the kind of plan on a page of what's happening in South Yorkshire for children and young people. This is our work in progress so far, but what it starts to show you is that we are aligning across the system the work that we've done within our integrated care strategy, within our joint forward plan, all the place work that's happening across Barnsley, Doncaster, Rotherham and Sheffield. We've got lots of our alliances and provider collaboratives that are maturing at the moment, but are starting to have areas of focus around children and young people, and some of those early years things that will be essential for future generations. And then we've got spaces where we know we've got sort of different projects underway. So the work around how the acute trust, the hospitals could work together in a different way around transition, for example, or safe space to sleep, the early years pilot and so on. And the National Centre for Child Health Technology is a really important one for me in terms of the leadership that we're providing from Sheffield Children's for that. But that will be a critical thing for us in the next couple of years about how we bring together academia with clinical care, with our patients and families, and think about what that future need is as well in developing the digital age of the future. And as Nicola said, the Children and Young People Alliance is about the kind of air that we breathe in between all of those and making those connections between us. And what's not on there is that there are only 3 independent specialist children's trusts in England, and we have one in Sheffield, in South Yorkshire, in our system. And so a huge opportunity for us as well as a specialist trust within Sheffield Children's to really increasingly focus on health inequalities. So then our last slide is just a kind of our reminder of our call to action. You'll see there the quote from one of our young people, and want to leave you with that kind of sense of we've got to create this snowball effect. We've doing some fantastic work so far. And this will be a legacy that goes beyond many of us that work within the system as well. We want everybody to feel safe. We want our children to feel loved and cared for and have access to care whenever they need it as well. And we've got our third conference that we're planning for our Children Young People's Alliance that will be in May next year. And our aim for that this time is that we shift the balance of having half of our delegates to be children and young people. So yeah, we're looking forward to that. We'll close there. Thank you. Really happy to take any questions if you've got time, but otherwise we'll pass back to you, Piers. Thank you.
Ruth, Nicola, thank you very much. That was great. I hope what people got there was not just a sense of the work that's going on, but how we do it. The theme all the way through this is we know we can only improve health by working in partnership. So how we do it is critical. And the other thing I hope you get from both those presentations, and indeed from the others as well, was our values. The values of this organisation are as much about health equality as about anything else, and I hope that came through. We've now got up to about half an hour for questions, and I think the way we need to do this is if people put their hands up through Teams and someone magically will tell me what's going to happen next. So if people have got questions, we're happy to take them. Over to you. I've got Nora Everett. Nora, how are you? Happy for you to come in. Nice to see you on call.
Thank you. It was encouraging to hear what they're doing with children, but it's a shame that they don't seem to be working so well with the adult public. My question is, in the involvement report, they mention the first principle of the Start the People strategy, which is to put the voices of people and communities at the centre of decision making and governance. And on the back of that, I'd like to ask, how and when will you include and involve the South Yorkshire people, the adults and children, in the self-assessment, the new NHS impact self-assessment that all ICBs have to do, which has been newly published, especially the part that says building a shared purpose, and section that's one of the sections of this self-assessment. And item 4 talks about measuring yourselves on how lived experience is driving this work, and by lived experience they mean patients, staff and communities. And as I say, I'm just wondering when you're going to involve the people, staff and communities in self-assessing yourself. There are a number of categories. There's starting, developing, progressing, spreading and improving and sustaining. And myself, I would put you at just about starting, but I'm sure you'll assess yourselves more than that.
Well, first of all, Nora, thank you. And again, nice to see you. Let me start a bit and then I'll hand over to Andy, if I may, who heads our public engagement, if that's okay. The first thing I would say as chair of this organisation is we never say that we've done this, or certainly we never say we've done it enough. So we did a lot of work on public engagement around our strategy, which was reassuring. We got really good interest. But frankly, we need to do far more, and we need to do it far more often. I think that's a theme we're going to see over the next few years. We haven't got it. So the one thing I won't say to you is we've done enough and we've got it right. We've got an awful lot more to do. Andy, do you want to just talk through some of the work we're doing?
Hi, Piers. Absolutely. So yeah, Nora, thank you for your question. I think at the moment what we're doing is we're actually refreshing our Start with People strategy. So we recognise that we launched it on the 1st of July last year, which was a kind of great starting point for the organisation. And now what we're going to be doing is going back out to our communities and stakeholders just to update that document, because it's got us through the first year, but clearly now 1 year on, we need to review what we said we'd do and build on top of that. And then in addition to that, we've got a huge amount of work going on to go out to our community. So I think we've probably identified circa 300 lines in our joint forward plan that we think actually those are issues that we want to talk to our communities in the future, and they range really widely, from talking to people about non-surgical oncology across South Yorkshire, the health centres in Sheffield itself. So there's a huge amount of work going on there, but I think as Piers rightly alluded to just in his opening comments, so much more work that we can do, and we're working to both identify what that might be and to refresh the strategy behind it. So I hope that offers you a little bit of reassurance behind the fact that we are putting time, resources and energy into how we work with our communities. And I think the joint forward plan is a great example where I think more than 2,500 people in the end contributed to shaping that document and the themes behind it. But I absolutely take your point, much more to do.
Thanks, Andy, and thank you, Nora, for that. Any other questions from members of the public? Tim Brown. Tim.
Yeah, thank you, Chair. Can you hear me?
Yes, I can. Yeah, don't worry. Thank you. And I can see you as well.
All right, thank you. I don't know if that's a good thing or a bad thing.
Well,
but
I always ask that question.
Okay, thank you very much. I mean, thank you for giving me the opportunity to say a few words. It is with some trepidation that I'm going to say what I want to say and ask some questions. And basically, it's about, and I've mentioned this before, for those of us with the lived experience of those amongst us who were born into relative poverty and identify with being Black, and whose family members have provided over 200 years of loyal service to our NHS, is to be routinely victimised and have our concerns of racism ignored year after year by our municipal health and social care leaders in the city of Doncaster ever since the independent Gus John report about 20 years ago. So this has been going on year. But nevertheless, in current times, very recently, there was a report looking into our looked after most vulnerable children at Esley Children's Home. Yes. They had their hair cut off, without their consent. And as a parent, this is kind of heartbreaking. It really, really is. These, as I say, are non-verbal people, and it's still the case that in Doncaster, our municipal leaders still defiantly are failing to clarify what is meant by the "we do not see colour" philosophies to Black people or people who look like me. So I'm therefore respectfully asking the ICB leadership to share their individual and collective race equality smart actions to help to stop the abuse of our most vulnerable girls. And, we can help in the community. We've put forward solutions to the Equality and Human Rights Commission, and that has been accepted, and we were thanked for that. But in Doncaster, that's been kind of ignored, and that. So that's number one, and that. I think there's something about promoting anti-racism, and again, myself and other colleagues can help the ICB looking at that. And as I say, we are privileged in that. I mean, I believe I shared an office once with, was it Ben Anderson or what have you, almost 20 years ago in Rotherham, when I had the privilege of leading on a health inequalities project in Rotherham. I think I led on Healthy Living Barnsley, and it might have been the same Ben Anderson who shared an office way back then. So, as I say, we have always wanted to put forward ideas. We have been part of the NHS for a long period of time. I'm not a young chicken, but, you know, it just hurts me that our lived experiences in terms of where we live is one of we're just ignored. And then the final aspect to this is whether or not you know, the leadership board has showed due consideration to my mentors or colleagues of the likes of Yvonne Coghill, who used to lead on the RES and that, or Stacey Johnson, who has supported me in terms of being part of a reverse mentoring program in other parts of the ICB family and that. But again, putting forward such suggestions in the area where I live for whatever reason, and I can only think it's because of the colour of our skin, is that it's routinely ignored as though, you know, we've got nothing to contribute. But on a positive note, I have had some correspondence from Andy Ashcroft, I believe. Yep. And I think he is, and it's credit to this ICB, that he is receptive to opening up a dialogue, not just with myself. And, you know, I'm here today and I am a bit nervous. I will be punished for speaking out because that's what happens. I know colleagues are shaking their head, but that is my lived experience. And as I say, you know, I've lived in Doncaster all my life. And that, as I say, I've contributed to the NHS over 25 years. My sister is a senior midwife over 30 years. You know, so, you know, I've raised my children in Doncaster who can't get a job in Doncaster because he's black, but actually he's just been appointed as an investment banker in the City of London. Now, how can somebody explain those kind of lived? So those are our lived realities. It's not me just making those up. But what I'm saying is, so those are the kind of questions in terms of, I want to help address, promote race equality, tackle any race inequalities that exist, not just in Doncaster, but in the region. And as I say, I have been fortunate that I have worked in the system. I want to contribute. And there's other people who live in and around Doncaster who want to contribute. And I'm hoping going forward that these people will be given the psychological safe space for them to help colleagues on this call to make a difference. Thank you very much.
Tim, thank you. Let me start off, and then Gavin, I'll hand over to you if you don't mind. So a couple of things. Firstly is, you know, we should all be sobered by your story. The first thing, and I certainly am. So thank you. Thank you for coming on, being really honest. That's what these public meetings should be about. Secondly is, we think we're doing a lot. I'm not sure we're doing as much as we should. So we should be talking to you and making sure we do more. We've done a lot to try and get our board right. We've done a lot to try and make sure that we reach out into communities that we've traditionally not reached out into. And a lot of the health equality work is as much about race equality as it is about anything else. But that doesn't mean we've got it right. We are doing work with our staff, and I don't mean the staff just in the ICB. I mean the staff across NHS South Yorkshire. Our staff are a really, really scarce and valuable resource. We cannot afford any of them, regardless of background, to feel anything other than valued. And if they do, we've got big problems. But actually, the thing is, it's really important that you raise it with us, and we'll pick that up and we will try and use you. Gavin, I don't know whether you want to add anything.
Yeah, thanks. First of all, just to say a big thank you to Mr. Brown. It takes a lot of courage to come on a call with strangers and I think be so open with us. So just to say, I really appreciate that. And to be frank, a lot of what you said, it really resonates with me. So, you know, probably two things I'd reflect on. One is, you know, when we talked about health inequalities today, let's not you know, beat about the bush. A lot of those health inequalities relate to minoritized communities, and we know people from those communities have a poorer experience of both in terms of accessing services we provide as an NHS, but also have a poorer experience in terms of their health and their health outcomes. And I mean, I'm sure Ben could list lots of examples where you can quote very specific numbers that would illustrate that. So it's not a matter for dispute. It's a fact. It's an uncomfortable fact. But I think when we do our work around health inequalities, I think that's absolutely at the forefront of our thinking. I think the second thing that resonated with me was, and I mentioned us as an employer. I mean, you know, we're a massive employer, health and care. You know, so I think we've got a real opportunity to be a bit of a beacon about what good employment looks like. But when I look at you know, the RES data, the workforce rate equality standard data for NHS organisations in South Yorkshire, got a hell of a long way to go, to be honest. You know, if you're black or from a minoritized background, you're much less likely to get promoted above a certain level. You're much more likely to find yourself in a formal disciplinary process. You're much less likely to get the job if you get shortlisted for it. I mean, you know, again, this isn't speculation. These are facts. There's data that supports this. So one of the things, and I know Christine, our Chief People Officer, on the call, but one of the things we're really passionate about is how do we use our power as an employer to be a better employer and set an example. I mean, you mentioned reciprocal mentoring. I mean, one of the really good things that's happening in South Yorkshire is a reciprocal mentoring programme, and that the second cohort is just underway. And myself, and I know David Crichton, who's on this call, is the Chief Medical Officer. We're both you know, with a good degree of humility, participating in that programme. And I think one of the reasons why I'm keen to do that is because I can make assumptions about what it's like to be from a minoritized community and work in the NHS, but it's just assumptions. You need to hear it from people who, you know, like you've done today, what's your lived experience. But I think what I'm really keen on is how do we make the leadership of health and care organisations in South Yorkshire more diverse? Because the problem with them, I mean, to be frank, the problem at the moment is if you look at people in senior leadership roles, you know, it's not particularly inclusive. And I think if we can change that, if we can get more aspiring leaders from minoritized backgrounds into those senior roles, I think we get two benefits. One, we make better decisions as organisations. You know, and if we're going to address health inequalities, I think that will help us with that as well. And the second is we're more likely to attract people. We're missing a massive trick in South Yorkshire. We've got workforce and vacancies, or our ability to recruit is a big challenge. And yet in these very same communities, economic inactivities, what's driving poor health, we've got to be able to put those two things together. But we'll only do that if we look like an organisation that's welcoming and open for people who look different than I do. But there's not an easy answer to the points you're making, Mr. Brown. But all I'm saying is I think a lot of what you said will resonate with a lot of people on this call.
Christine, do you want to add something as our Chief People Officer for the ICB?
Thank you. Thanks, Mr. Brown, for your comments. I won't repeat everything that Gavin and Piers have just said. I just wanted to pick up a couple of points. One is around the objectives of the board in terms of collectively and individually. And I just wanted to highlight a conversation that we had at our board meeting last month, where we did an update around what we've done in respect of equality, diversity and inclusion, and around anti-racism. And as part of that presentation, there were some challenges that I made to our board colleagues. One was to have an individual objective, which is measurable and impactful, around inclusion, equality, diversity and inclusion.
Now, that could be something that they are particularly passionate about. It could be particularly an area in which they're quite comfortable, but it needs to be measurable. So that as a board of a certain size, that is 20 plus individual impactful actions that we can do. And we've also created a board level leadership group across South Yorkshire to try and harness all of the boards of South Yorkshire so that we can see the impact of those. The second challenge was to go into a space which is much less comfortable and potentially a much more learning space. And I asked our board members to lead with humility in this space and to go to a place where they aren't comfortable and to learn something specifically about themselves or about an area in which they're not feeling particularly well educated on. So those two challenges were readily accepted by the board, and the notes and I think of the recording will confirm that we had some contributions from board members around the table about areas that they would like to pick up straight away. So I want to assure you that we are taking that serious, and there is very strong leadership around that, led by Piers Butler, our chair.
Thank you, Tim. That was a great question. Any other questions from members of the public? Okay, I don't see another hand going up. So can I thank you all for attending? Can I thank you those who've raised questions, really good questions about challenging us, which is what is right. And those of you who are at home, just go and make yourself a cup of tea. Those of you who are going somewhere, have a safe journey home. Look after yourselves. Thank you very much for joining us. See you now.
Thanks, everybody.